grant funding as principal investigator. Some of the research that I'm currently doing and have done in the recent past has been funded by CIHR and the Heart and Stroke Foundation. The other disclosure I should put forward is that I'm actually not a transplant physician. I'm a general pediatric cardiologist, an echocardiographer. So it was a bit of a pleasant surprise to be invited to talk at ATI rounds. But a lot of commonalities exist between the patients I primarily take care of, adolescents with congenital heart disease, and those who've had a solid organ transplant. And I hope that I'll be able to relay some of the learnings that my team and I have acquired over the past decade or so, because I think that many of them will apply to your patients as well. So my objectives are, by the end of this presentation, I hope you'll be able to describe the challenges encountered by transition-age youth, summarize some key concepts of transition preparation, and identify at least one way of improving transition-related care and clinical practice. I got the talk structured as follows. We'll talk a bit about some of the gaps. Second, what evidence is out there in the solid organ transplant world? Where is there evidence lacking? And I hope to leave you with some practical tips. So first, a couple of definitions. What is transition and what is transfer? And I raise this because these terms are often used interchangeably. However, transition is a process, and it's been defined as the purposeful planned preparation of adolescents and young adults in order to enable them to succeed in the adult healthcare system. It's meant to foster developmentally appropriate skill acquisition, and it takes time, usually several years at least. And importantly, it spans both the pediatric and the adult healthcare systems, because the process of acquiring skills needed to manage their care is not complete by age 18, as many of my adult colleagues will attest to. Transfer, on the other hand, is an event, and that's when the responsibility for care moves from the pediatric providers to the adult providers. So this figure illustrates the development of self-management skills on the y-axis and age from early adolescence to about 25 years of age. And the point is twofold. First, it's not complete at the time of transfer, which in Canada is typically about 18 years of age, but is often a bit older in the US. And the second point is that it's not a straight line. There are plateaus and then other periods of time when the acquisition of self-management skills and readiness for transition increase more rapidly. So I'd like to begin this with a case of a 19-year-old female with a history of dilated cardiomyopathy leading to a heart transplant at age 11. She was last seen in the pediatric transplant clinic 6 months earlier and had moved out of her parents' home, as many young adults do. And she couldn't be reached any longer, not only by the adult transplant team, but the pediatric transplant team weighed in and tried to get hold of her as well. And even with parents' help, it didn't happen. She'd stopped taking her immunosuppressants, as her mother suspected. She showed up in a walk-in clinic with fever, breathlessness, and fatigue, and was treated for community-acquired pneumonia. And 2 days later arrived and emerged with cardiogenic shock and fulminant rejection.
Yeah, sounds good. Thank you.
This may sound like a bit of a drastic case, but unfortunately, there have been more than one case that our pediatric colleagues can attest to in terms of graduates from the pediatric transplant program. So with that case in mind, we're going to talk just a little bit about young adult survivors and the current challenges that youth face with respect to transition. So of course, they're going through multiple other life transitions, as this case illustrates: school, jobs, new partners, and other distractions. And of course, going to medical appointments isn't priority number one, and neither is taking immunosuppressants. This is a period of changing influences where healthcare providers fall in a much smaller circle, as do parents. And peers, on the other hand, in social media, have a much stronger influence on the actions and behaviors and priorities of adolescents and young adults. And psychologists have coined the term emerging adulthood, which is a unique developmental period between the ages of 18 and 25, when there are still neuroanatomic and cognitive changes that are occurring. And anyone who has an adolescent at home or who's been an adolescent in the past can probably relate to this cartoon. And of course, it's just a cartoon and just a joke. But the reality is that for our patients with chronic health conditions, including those who've had a solid organ transplant, there are additional challenges beyond those faced by healthy youth. These challenges exist because frequent hospitalizations and medical appointments result in some school absences, in some cases, disconnection from peers. Our patient populations have a higher incidence of anxiety and depression relative to the general population. And they can develop, in some young people, difficulty identifying an identity outside of their chronic illness. And all of these challenges really complicate the ability to manage their chronic illness. And so this is a period of not only high psychosocial risk, but a period of high medical risk. And if you're interested more in this topic, there's a nice review published this year by colleagues at the University of Michigan. And basically their messages from this review article are that many adolescent and young adult transplant recipients have compromised executive functioning skills. And this has implications, of course, for their decision-making, their regimen adherence, and their ability to transfer successfully to adult transplant care. And they recommend serial monitoring throughout adolescence and early adulthood of neurocognitive development and transition readiness. So the consequences of transition include not only healthcare dropout, but sometimes difficulty attaching or engaging to adult providers, poor treatment adherence with respect to immunosuppressants and other medications, resulting in increased emergency room visits and increased hospitalizations. And this is true across multiple chronic health conditions. With respect to the consequence of transition and kidney graft failure rates, Beth Foster, who's at McGill, published a very nice study quite a few years ago. This is based on US data of kidney graft recipients under 40 years of age. And irrespective of age, among those who've had a graft survive at least 1 year, you can see that the highest age range for graft failure was 17 to 24 years of age, corresponding entirely with this phase of emerging adulthood. Beth also published another paper looking at the age of transfer to from pediatric to adult care on the risk of graft failure in renal transplant recipients. And on the top half of this figure, we have individuals whose transfer happened at age 21 or later. And each horizontal line represents a unique individual. And those who were transferred in the late age group, meaning between 21 and 30 years of age, had a graft failure rate of 8.7 per 100 person years. Comparing that to those below, in the bottom half of the figure, these are young people who were transferred to adult care before the age of 21, and their failure rate was 12.9 per 100 person years, substantially higher. And the conclusion that these investigators came up with is that perhaps some transplant recipients are not ready to enter the adult healthcare system. They don't have the skills needed to successfully and safely arrive in the adult healthcare system before age 21. And maybe we should rethink the age of transfer and be flexible. So what are the perspectives of youth and their parents on transition? Of course, these are general statements, and they don't apply to everyone, but in general, youth feel unprepared to manage their health, particularly if they've not been through a comprehensive transition program. Many lack basic self-management and self-advocacy skills. They don't know where to turn for help when they start developing symptoms or have an evolving medical crisis, explaining the increasing rate of emergency room visits. Some feel quite attached to pediatric providers, and of course, some have cognitive delay. Parents, on the other hand, have great difficulty of letting go of some of the healthcare management that they've taken responsibility for many years. They have very strong attachment to the pediatric providers, often more so than the youth. And as a result, are quite wary of the adult system providers. And of course, they also remain invested in the health of their young adult child. And this is a very anxiety-provoking process for parents. I had the parent of a 19-year-old with complex congenital heart disease described to me recently that she was literally terrified of her child entering the adult healthcare system. What about provider perspectives? Well, pediatric providers sometimes regret the relationship that they lose with the patient and family, and may be reluctant to transfer the patient. They may lack the skills, times, and resources to help prepare adolescents for transition. And of course, in some cases, they will feel that their patient isn't ready for the adult healthcare system. Whereas adult providers have expressed concerns about the maturity of patients who arrive in their clinic at 18 or 19 years of age. They're concerned about the high psychosocial needs in some cases, facing disability or end-of-life issues, the lengthy visits that are often required, and families' high expectations. So everyone has a perspective on the transition process, and they're all valid. And of course, there are differences between the models of care of the pediatric and adult system. In the pediatric system, we like to think of ourselves as holistic and nurturing and family-centered. And yes, we don't have as many patients to take care of, and we have a bit more time per patient. Whereas the adult system is very autonomy-focused and expects that of 18-year-olds, but the reality is 18 to 25-year-olds are not the same as a 40-year-old. The adult system also expects patients to advocate for themselves, to be able to manage their own health and make appropriate treatment decisions. And youth perceive providers as time-strapped and relatively unavailable compared to what they're used to on the pediatric side. So as a consequence of all of these challenges, going from pediatric to adult care can feel like jumping across a huge and dangerous chasm. So we're going to talk now a little bit about the evidence that surrounds transition preparation. I've focused on Canadian literature as much as possible in the solid organ transplant world. Most of the literature does come from renal transplantation. And so my apologies to those who are more interested in liver, heart, or lung, but there's a lot more data in the kidney transplant population. So a really interesting study published now 3 years ago, which is a multi-center study in Canada. It was a prospective observational cohort. They followed participants for 6 months. And they had a large number of youth aged 14 to 25, a total of 270 in total. A bit more than a third were followed in pediatric programs, and just under 2/3 were followed in an adult program at the time of enrollment. And this was a diverse population of kidney, liver, and heart transplant recipients. And they measured adherence to medications at baseline, 3 months, and 6 months using the BASIS self-report tool, which had been previously validated. And the conceptual model behind this study is really quite comprehensive. So on the left-hand side of the screen are the program level factors that they looked at in terms of predictors of adherence to medications. Whether or not there's a pharmacist on the team, minimum prescribed frequency of blood draws, minimum prescribed frequency of clinic visits, whether the same nurse was present at each clinic visit to develop a rapport with the participants, whether or not there were self-management interventions, and the average amount of time that the nurse spent with patients. And the patient level factors you can see are divided into non-modifiable factors like age, sex, and potentially modifiable factors listed in this box, including health literacy and self-efficacy, and partially modifiable factors like who the primary caregiver is and the number of medications they're on and mental health challenges and so on and so forth. And what they came up with or found was that multiple patient level factors were associated with better adherence to medications. And this included having fewer worries about immunosuppressive medications, having greater satisfaction with care, and having greater self-efficacy. Self-efficacy is the belief that they have the ability to get a task done, such as I have the ability to refill my prescription or to take my tacrolimus or whatever. And so of relevance to this finding is that these are all factors that clinicians, doctors and nurses and pharmacists and so on can address during appointments and have some influence on. Now, for sure, self-efficacy is not something that you can change with a 5-minute conversation. That certainly takes much more time. But these are all factors that we as providers can influence. They also looked at program level factors associated with better adherence, and they found that the minimum number of blood draws per year for those who are more than 3 years post-transplant was associated with a significantly improved adherence to medication. It's an odds ratio of 1.12. So this means that for each additional blood draw per year that was routine, there was a 12% increase in medication adherence. Possibly the blood draw is serving as a reminder of the importance of compliance with medications. And what I thought was really interesting was that the average time spent with nurses increased medication adherence as well, with an odds ratio of 1.15 for every 5 minutes. So to me, that is absolutely huge. This means that on average, each additional 5 minutes spent by a nurse with the patient increased medication adherence by 15%. That is a huge difference. I mean, imagine a 20 or 30-minute conversation can have a huge impact. And so the conclusion of the authors is down there below. And really lots of learning points from this study. Now, what about organizing young adult clinics where pediatric and adult providers come together? This is another Canadian study from Toronto, where, excuse me, the pediatric and adult transplant programs organized what they called a transfer clinic for 18-year-olds. And it included, of course, the pediatric providers, the adult providers, as well as adolescent medicine specialists. And patients came to the clinic just once. All of them were 18 years of age. And this, of course, facilitated communication between the pediatric and adult teams about individual patient. It allowed face-to-face meetings between the patient and the adult team, which provided some comfort to patients leaving the pediatric system, knowing that they'd met their adult providers at least once before they entirely left the pediatric system. And of course, it allowed the patient to meet with an adolescent medicine doctor as well. It was a small study. They had 16 in the transfer clinic group, and they compared them to 16 controls and looked at non-adherence, which they defined as missing clinic visits, missing regular blood work, and undetectable calcium urine inhibitor levels, and followed the participants with respect to non-adherence for 12 months after participating in the transfer clinic. And those who'd been through the transfer clinic had a 19% non-adherence rate, which is significantly lower than that had existed with historical controls. Not only that, but those in the transfer clinic had less of a drop in their eGFR in the year post-transfer compared to those historical controls. So really interesting data on this small study. And then the BC group also described their experience with a young adult transition clinic. And what they looked at on the y-axis is the composite outcome of death or graft loss. And of course, on the x-axis, we've got time up to 24 months post-transfer. And the dotted line refers to those who've been through the transition clinic, and you can see that they're right across the top here. So there were no deaths or graft losses in that group in the first 24 months. Unlike the PTC group or pre-transition clinic group, where they were event-free in 76%. So in other words, 1/4 of patients in the pre-transition group had either a death or graft loss. And of course, as you can imagine, the cost of managing these patients varies substantially. For those who've lost their graft, the costs were much higher than those who've not. And then a very unique study that is in press and should be published in the next few months, I would imagine, is about peer-to-peer mentorship. And this is a study that the Stollery participated in. Simon Urschel was our lead here. And this is a study about one-to-one virtual peer mentoring for solid organ transplant recipients. In this study, they were heart and lung transplant recipients. The study included 20 mentees who were aged 12 to 17. About 2/3 of them happened to be female, and 9 mentors who were on average about 6 years older. Again, the majority were female. And the mentors were all transplant recipients who had successfully transitioned to adult care. And mentors met with mentees every 1 to 3 weeks over a 15-week period. The average number of calls, and these were virtual visits, the average number over the 15 weeks was 5, and the median call length was 22 minutes. And the mentors have been trained in advance over the course of a weekend workshop in terms of topics to cover. And the mentees describe benefits in terms of increasing their self-management skills and fewer symptoms of depression and anxiety. And in terms of the qualitative analysis that came from the study, there were a number of themes that came out, but quality of life and resiliency were a couple of the themes. And I'll just read a couple of these quotes in the resiliency section. And these are quotes from mentees. "This experience impacted me like crazy good. It gave me more hope and things I guessed to expect in the future." Another mentee, "It definitely boosted the way I feel about myself, and I feel more open to talk about it with others after the program. And I feel like whenever I do transition, I have better answers than I had before." There's no numbers in terms of, rejection or emergency room visits or hospitalizations or anything like that. But from the qualitative analysis, you can see that there was significant benefit derived not only from the mentees, but also the mentors themselves. So I'm going to switch gears a little bit and talk about knowledge of the condition. And I did a lit search trying to find a randomized controlled trial on structured transition preparation in terms of focusing on education about the transplant. And I didn't come across anything. So please allow me to talk about congenital heart disease for a bit. It's been very apparent to cardiologists like myself that teens and young adults with CHD have very limited knowledge of their heart unless we as providers do something about that. But an interesting study that came out of Sick Kids about 15 years ago demonstrated that teens who are knowledgeable about their CHD are more likely to be confident communicating directly with doctors or nurses rather than having their parents do so. And of course, being able to manage your health in the adult healthcare system is all about being able to communicate effectively with your providers. So this got me thinking, well, we need to do something about the knowledge gap that our adolescents with CHD have. So I designed a clinical trial which had the aim of developing and evaluating a clinic-based transition intervention and educational intervention for youth with CHD. And we measured knowledge of their condition and self-management skills pre and post. We called it the CHAPTER study. The acronym's there for you to read. It was an RCT of 15 to 17-year-olds with moderate or complex CHD, and there were 2 groups. The intervention group, which met with the nurse for about an hour in the clinic, and then a control group. And I'm just going to describe on the next 2 slides what the intervention consisted of. So the nurse, this is one of our nurses, Michelle Shu, and a participant who agreed to have her photo taken. So they met privately in a quiet room with a computer without a parent and discussed transition and what that means. They created a health passport, which was a portable, simple summary of the name of their cardiac conditions, their previous cardiac surgeries and catheterizations, and the name, dose, and rationale for the meds they're on. They reviewed the participants' anatomy using a diagram, and they discussed potential late cardiac complications, sending the message that they're not cured from their CHD and that this is a lifelong condition. The nurse provided the participant with the names of the CHD providers on the adult side. There was some discussion of risk-taking behaviors using third-person scenarios. The youth took home some youth-friendly materials about sex, drugs, and rock and roll. They were introduced to some patient-oriented CHD websites, and then the nurse followed up with a participant by text or email, depending on their preference, within 7 days. Because often there were outstanding questions or issues that came up. And we looked at knowledge over a 6-month period. We got enrollment here on the left, and then 1 month and 6 months. And using the MyHeart score, which measures CHD knowledge, we found that the intervention group in green had a significant increase in knowledge scores at 1 month. And we were surprised, but pleased to see that their scores were maintained at the 6-month point, probably because they had their health passports, which they could refer to whenever they wanted to. And we were also interested in looking at the acquisition of self-management skills. And even though we didn't train them or coach them anything about self-management, we saw that the intervention group in green also developed increase in self-management skills by the 6-month point. Another thing I should emphasize on this slide is that the usual care group, or the control group in red, also had an increase in self-management skills. And this highlights the need to have a control group when you're evaluating self-management, because it increases with increasing age. So what is self-management? A little bit more about that. So it's basically a set of methods, skills, and strategies by which individuals with a chronic health condition can effectively take care of themselves in partnership with their providers. And so that will include, of course, strategies to take their immunosuppressive meds on time every day, or strategies to get their blood work done at the right time, and strategies to get themselves to the lung transplant follow-up clinic. And all of this requires some knowledge of their health condition, some problem-solving skills, access to and confidence in supports when they have questions. But of course, it also requires some emotional well-being. In other words, mental health. Challenges, anxiety and depression, can really get in the way of self-management skills, or following through on self-management skills. And this underscores the importance of recognizing coexisting mental health challenges and being able to address those. So the Chapter 2 study asked the following question: what's the role of a nurse-led coaching session focused on self-management? And second, what do transition interventions do with respect to attendance in the adult clinic? And finally, what is the long-term retention of knowledge beyond the 6-month point? And so this was, again, a cluster randomized trial of 16 and 17-year-olds, and it was similar to the Chapter 1 study, except that the participants met with the nurse twice, not once. And this happened at Stollery and at Sick Kids, and the number of participants was about twice the size. This first session was similar to the Chapter 1 study. The role of the nurse was to be a teacher, to inform the youth about their heart condition. It lasted about an hour. There was a goal-setting exercise at the end of that session, and a brief visit to the adult clinic so they knew where to go when it came time for their first adult appointment. Otherwise, the content of this session was the same as what I described before. And then the second session was held about 2 months later, and the role of the nurse in that session, and it was the same nurse, I should point out, was not to be a teacher, but more of a coach or a facilitator. It also lasted about an hour, and the nurse reviewed the goal-setting exercise with the participant, and they discussed some important self-management skills, like how to make an appointment, how to get ready for an appointment in terms of thinking about what you're going to tell the providers, and what questions you want to ask of the doctors and nurses. Also, filling a prescription was covered, and there's some role-playing scenarios. One role-playing scenario in an emergency room, and in another role-playing scenario that involved a typical transplant follow-up clinic. Sorry, a CHD follow-up clinic. What we found after these 2 sessions was that the probability of attending the first adult cardiac appointment was more timely in the intervention group in blue compared to the usual care group in red. On the x-axis, we have excess time, which basically is delays beyond the recommended time to the first adult appointment. And I'm sure you would agree that getting to the adult transplant clinic in a timely manner is important for all solid organ transplant recipients. We also looked at retention of knowledge, and we found that the intervention group in blue had retention of knowledge about their CHD 18 months out after enrollment, and that was higher than in the usual care group. And we also looked at self-management skills out to 18 months, and at all time points, they were higher in the intervention group, but they did increase over time in the usual care group as well. We did a qualitative analysis as well. We asked the participants from the 2 sessions, what was most helpful to you, most meaningful to you. This is what came out: the creation of the health passport, the goal setting exercise, and the role playing scenarios in the 2nd session. Changing gears slightly, because so far I've talked about older adolescents, what about young adolescents? And if you look at guidelines put out by the Canadian Pediatrics Society or the American Academy of Pediatrics, they emphasize starting by 12 or 13 years of age, but there's really been no data in that age group up until recently. We all know that 13 and 14-year-olds are developmentally distinct from older adolescents, and their needs are a bit different because they're not imminently going to enter the adult healthcare system. So we tailored educational intervention for 13 and 14-year-olds with moderate or complex congenital heart disease. And again, this is a single center RCT here at the Stollery, and randomized those to nurse-led transition preparation versus usual care. And we found that the intervention group, this time in red, had significantly higher knowledge scores about their congenital heart disease at 1 and 6 months, very similar to the previous studies. And to a lesser degree, they acquired higher self-management scores compared to the usual care group. And the point of this study is that basically it demonstrates that 13 and 14-year-olds are old enough to start learning about their condition and to start taking on some responsibility for managing their health condition. So that's what we published on the chapter studies, but what I would say we really learned but didn't publish is that you need dedicated nursing time to do transition preparation well. And I'm certain that that is equally true for solid organ transplant recipients as it is for CHD patients. You need some dedicated teaching space within the clinic area where there won't be interruptions and distractions. The interventions ideally need to be on the same day as a clinic visit. We found that on the occasion that didn't work out, it was really quite challenging to schedule the participant to meet at a different time. Some parents struggled with being left out. Many didn't, but a few did. And finally, we learned that health passports need to be smartphone friendly, and we've now done that. So the standard apps that exist on a phone, like the Contacts app and the Calendar app and the Notes app, all of those are used for creating a health passport. Switching back to the solid organ transplant population, a really interesting and novel study published by Simon recently, a couple of years ago, had the following aim: to create an educational resource meant to motivate teen heart transplant recipients to take an interest in ownership of their long-term health. And in order to develop this educational resource, the team worked with 4 teens, 4 parents, and 3 healthcare providers who provided insights through interviews on how this resource should come together. And the output of this is a graphic novel, yes, with mutant worms, secret plots, and daring escapes that addresses the medical concerns, and it is written in a way that is motivational and patient-centered. And on the left-hand side here is the front cover of this book called The Cure. And on the right-hand side is just an example of a page from it. You can see that it's a graphic novel, and it's written in a way that is meant to engage and interest teens. And I think it's absolutely terrific. And if you want a copy, find Simon. I'm sure he'd be happy to share that. All right, just to summarize where we're at so far. So when I think about potential transition interventions, I think about those that are at the patient level and at the system level. And we've talked about teaching teens about their condition, and we've talked about developing self-management skills in teens, and we've talked about peer mentoring. But what is the data, if any, on patient navigation or parent support? And what is the data on the role of technology in all of this and group-based transition preparation? And this is really where we have much less data or no data yet. And this brings me then to the section on where we're lacking evidence, and these are really opportunities in the transition research arena. So patient navigation. You know, you've heard of the roles of a patient navigator or a transition coordinator or a case manager, and these are overlapping and often used interchangeably to describe individuals who, in the healthcare setting, can provide support in multiple domains for patients in ways that doctors and nurses don't traditionally do. This can include the acquisition of self-management skills and coaching, but also literally navigating the complex medical system. And where necessary, addressing and mitigating socioeconomic barriers to actually taking time off of work and getting oneself to an appointment. And the whole concept of patient navigation creates an opportunity for us as a healthcare team to increase healthcare equity and accessibility for those who are more marginalized and experience more difficult social determinants of health. And in my experience, I found that working with a navigator who's a training in social work, at least at the bachelor's level, has been extremely valuable. And I'll tell you about that in just a moment. But a really interesting study in type 1 diabetes, a Canadian study of 205 youth aged 17 to 20, looked at the role of a navigator in this chronic health condition. And about half of participants worked with a navigator for the last 6 months in pediatric care and the first 12 months in adult care, whereas the other half of the participants did not. And the transition coordinator group had increased clinic attendance on the adult side. They reported greater satisfaction with care, less diabetes-related distress, and a trend towards a lower hemoglobin A1C, though there was no change in the rate of decay or hypoglycemia over time. And so my colleagues, Susan Samuel and Gina Dimitropoulos from the University of Calgary and I, we thought that we should apply patient navigation to a broader range of chronic health conditions. And so we were funded by CIHR to conduct the Transition Navigator Trial, or TNT, which is a pragmatic RCT of 16 to 21-year-olds with a chronic health condition, which had the goal of evaluating the effectiveness of a patient navigator who's a social worker by training. We had one social worker here based at the Stollery and another based at Alberta Children's Hospital. We collected lots of quantitative data, but also qualitative data from surveys, interviews, and journals. Our primary outcome was all-cause emergency room visit rate, and we enrolled patients from across the province. And the focus of the navigator's work was really to work with 16 to 21-year-olds as they leave the pediatric system and are jumping this chasm between pediatric and adult care and adapting to the adult system. And there are some quite unique aspects of the role that these navigators were trained to do and were able to take on. First of all, they took a whole person approach, unlike what we tend to do in subspecialty clinics like the cardiology clinic, where we tend to get very focused on the heart and less so on the overall individual. And the navigator was able to create links to the community in education, housing where necessary, because some of our participants did not have stable housing, connections to the community with respect to mental health and addiction resources, and financial assistance as well. So for example, giving them bus passes to get to appointments, or providing taxi trips, or providing them with other strategies to get to appointments that they otherwise would not have had the opportunity to come to the clinic. So in terms of progress, we enrolled 334 patients. We were doing this during COVID, which made enrollment quite difficult once March 2020 arrived. It is the largest transition intervention study to date. In terms of our primary outcome, there was some evidence of significant effect modification in that there was substantially lower ER visit rates for those who had a mental health condition and who had the opportunity to work with a navigator. But those who did not have a mental health condition, there was no impact of the navigator on our emergency room visits, which just emphasizes that, of course, transition is a multifaceted, multidimensional process, and there are many different interventions that we need to look at. Sorry, many different outcomes that we need to look at. There are three themes that emerged from our qualitative analysis, and these included emotional support that the navigator provided, task focus support, and guidance to become more independent. And here are some examples of quotes that the patients provided to support those three themes. And we also interviewed healthcare providers whose patients were enrolled in the study. And what we learned from the providers is that from their perspective, and I'm talking about pediatric doctors and nurses and dietitians and pharmacists, what we learned is that navigation accomplishes a number of goals, including providing valuable support for adolescents at a vulnerable life stage, mitigating barriers to accessing care, providing equity and accessibility for all patients and families, and setting up youth for success as they graduate from the pediatric system. Changing gears again slightly to the idea of technology. Transition, is there an app? Well, it turns out that thanks to my colleagues at McMaster University and McGill, and I had a little bit of input as well, but not as much as them, we do have a transition app focused on youth with congenital heart disease. There's also a similar app for those with brain-based disabilities. None in the solid organ transplant world yet, but that could change. This is the Ready or Not study, and it's an RCT comparing the transition app versus nurse-based teaching. For youth with congenital heart disease, the app comprises 20 modules, and each one takes about 10 to 15 minutes to get through. We've enrolled patients at 4 sites. We have 207 patients enrolled, and we're still following them for another 12 months. And here's some screenshots from the app. So here's a brief video, about 30 seconds in duration, of a young adult who's gone through transition and is speaking some words of wisdom, so to speak. They also can create a smart heart pass, which is basically a health passport within the app. And then we ask them transition readiness questions. So this is from a validated questionnaire, the transition queue, which we built with permission directly into the app. So finally, the last few minutes, I just want to leave you with a few practical tips. From my perspective, the key elements of a transition program include, but are not limited to, the following: providing participants, adolescents and young adults, with some knowledge of their condition. So what health problem led to their transplant? Why do they need to take an immunosuppressant? Why do they need to do lab work? What are the potential late complications? What are the complications if they don't take an immunosuppressant? And the emphasis that this is a lifelong condition that they have and that it's not going to go away. We can also help adolescents and young adults acquire self-management skills, as well as self-advocacy skills, something I didn't really have time to talk about today. I would say that navigation seems to be particularly important for those who have a mental health comorbidity and those with challenging social determinants of health. We've also learned from teens in a number of studies that if they have the opportunity to meet the adult team before leaving the pediatric system, that is a great way to reduce anxiety. And finally, engaging and supporting parents and not ignoring them through this process. With respect to helping teens with knowledge of their condition, I suggest starting by age 13, if not earlier. meeting one-on-one for part of the visit, coordinating this with routine clinic visits, be that in-person visits or virtual visits, and our nurses do virtual visits very successfully. Progress at the teen's pace, emphasize the need for lifelong care. The adult providers that we work with need to continue education beyond the age of 18, and we need to accommodate for those who have lower health literacy. A few tips for engaging adolescents: try to be non-judgmental, give them control over what topics you discuss to some extent, ask them about their interests and goals, and ask them for feedback. You know, is what we talked about today helpful? What would you like to talk about the next time you come? Try to remember how you felt at that age. I'm well north of 18, so it's a little bit difficult sometimes. But if you can try and remember what it was like to be a young adult, that can put yourself in their shoes, that can certainly help. Acknowledging that this can be overwhelming, encouraging them and congratulating them on small goals, and providing tangible goods. And this is where you need a social worker to help with meal vouchers and taxi vouchers and bus tickets and so on. And as somebody who's a doctor, you need to realize, if you are a doctor, that you can't do this all on your own. In fact, I would say that nurses and social workers are much better at this than we are. So get help. With respect to working with parents, explain the rationale of fostering their young adult child's independence, inquire about their concerns, take advantage of their insights, and reassure them that they're still part of the team, which is very much true. And finally, if you haven't already created a transition clinic within your program, consider doing so with a multidisciplinary team. Transplant physicians on the peds and adult side, nurses, adolescent medicine specialists, social worker, pharmacists, and psychologists, and perhaps others as well. And consider a flexible age at which young adults come to this multidisciplinary clinic, depending on the patient's readiness for leaving the pediatric system. And finally, evaluate how your transition clinic is working out. Now, seek feedback. And finally, with respect to transfer, you want to, as a pediatric program, inform patients well in advance, consider the developmental age, provide a comprehensive transfer letter, and avoid doing this during the medical crisis. On the adult side, responsibilities include developing a strategy to track referred patients, tracking the time intervals between the pediatric and the adult appointments, and please inform your pediatric colleagues of the transfer outcome. We really like to hear how our patients have done once they reach the adult clinic. So ultimately, what we're aiming for is all patients arriving in the adult clinic in a timely manner with knowledge of their immunosuppressants, a health passport on their phone, and some self-management and self-advocacy skills. We're also aiming for them to feel engaged with their adult team providers and wanting to return to the adult clinic rather than just going there once. And we're also aiming for equitable access to care, keeping in mind that adverse social determinants of health need to be addressed and mitigated. And finally, that we have the time, space, and human resources to do all of the above, which I acknowledge is challenging. So finally, a call to action. I would argue that all adolescents and young adults with a transplant should receive one-on-one teaching about their condition and self-management skills. Those with adverse social determinants of health or mental health challenges need extra time and resources from their providers. And in future research endeavors, let's engage more young adults with lived experience as partners in the research process and not just as participants. Please consider what a missed opportunity it would be, having invested so much in these young people throughout childhood, to not set them up for success in the adult healthcare system. Collectively, as providers, we have the responsibility to instill relevant knowledge and skills in young adults that will set them up for success in managing their healthcare over the long term. And with that, I'd like to acknowledge my collaborators in the Transition Navigator trial, the Ready or Not study, which is still ongoing, and the chapter studies. And I'd also like to thank Simon Urschel for providing me with some valuable literature and slides. And I'd like to thank you for your attention. And please feel free to reach out by email if you have any comments.
All right. Thank you, Dr. Mackie. Very, very interesting talk. I believe we have the privilege of having Dr. Samantha Anthony, who is involved in the chapter studies, presented in our audience today. So perhaps I will just invite her first to see if she has any comments on this very interesting topic.
Hi, thank you very much. An amazing presentation, Andrew. Thank you very much. I think you've highlighted, the immense work that's being done by scientists across Canada, looking at this important issue. And lots has already been done, a lot of innovative tools and techniques to support adolescents in their transition, but lots more can be done. So thank you for your call to kind of gaps in the knowledge and research, and calls to action, really meaningful. Thank you.
Thanks, Samantha. I didn't realize you're in the audience, but you've done amazing work with iPeer-to-peer, and I'll just mention that I have the good fortune of being able to collaborate with Samantha over the next few years on a iPeer-to-peer study in congenital heart disease, which I'm super excited about. But you and your colleagues at Sick Kids are truly leaders in this, Samantha. So thank you.
Thank you. No, it's been a great collaboration, definitely with the support of the Canadian Donation and Transplantation Research Program. We have within transplantation smaller numbers, so the importance of doing multi-site studies and having these ongoing collaborations across Canada, and also, including patients. So all of our research studies include patients from the inception of the project. So they design the research, methodology, and have been actively engaged throughout all of our different endeavors. We are also launching an iParent-to-Parent. So we've been quite fortunate. The success of the iPeer-to-peer program has been immense. So I think you've captured that nicely, both from a quantitative as well as a qualitative perspective. And it now has grown beyond solid organ transplantation to other chronic illness populations. Thank you. Always a pleasure to join you guys.
Thanks, Samantha.
Hi, it's Karen Johnston. I just, actually, this is a really timely meeting because I took an admin day. I'm the nurse practitioner for pediatric heart transplant, and I'm working on transition for specifically heart transplant. So if there's anybody out there who, is interested in collaborating, I would be delighted to hear from you, because, it is absolutely a life-saving medication. And if they're not taking it or they're not attending, these kids, young adults, have very poor outcomes long-term.
And I'll just add that for those who are not familiar with Karen's previous work, but Karen worked in type 1 diabetes and did amazing transition-related work with older adolescents with type 1 diabetes for many years. So Karen, I consider you a real expert in this area.
Oh, it's all a learning proposition with the new population.
All right, I see a comment from one of my colleagues on the pediatric kidney transplant side, Dr. Ulrich, in the chat there. So I'll just read that out. So curious what your thoughts are on more collaborative program development for all solid organ transplant programs in Edmonton/Stollery, rather than advocating for resources within programs or reinventing the wheel.
Yeah, thanks for the question, Dr. Ulrich. I mean, it's a great point. There are many common challenges that youth and young adults face, regardless of whether they have a kidney, liver, lung, transplant, or congenital heart disease, or type 1 diabetes. So to me, it completely makes sense, certainly across the solid organ transplant clinics, to share resources. I mean, many of your patients are on the same immunosuppressants, right? So that makes a lot of sense. I would also just say that there is a patient navigator who worked with us in the Transition Navigator trial that I described, and she continues, now that we've stopped enrolling patients in the Transition Navigator trial, she's continued to work in a full-time AHS role as a Stollery patient navigator. And her name is Kristen Tinge. I'll throw it in the chat. And she can be, you can reach out to her for patient navigation challenges that some of your higher risk youth face. And so she's available to all programs based at the Stollery. And also in terms of sharing resources, there's an AHS part of the AHS website called Well On Your Way, which has a number of resources for providers as well as for patients with respect to transition. So that's another way to not reinvent the wheel and to share resources.
Thank you so much. Yeah, I think just to follow up, I think it's especially topical right now because we have a lot more adolescent medicine support at the Stollery too. So certainly something that we're looking at in the kidney transplant program is optimizing transition care. So this was a really great talk. Thanks so much, Andrew.
Oh, thank you. I'm just putting in the box Kristen's name right there.
That's fantastic.
I put in the website as well.
Oh, thanks, Karen.
Thanks, Karen.
Yeah, Kristen's on the AHS email system, so she's easy to find.
Yeah, just
All
a
right.
plug for this too. The information that adolescents need are going to be very similar regarding of the type of transplant you have. And instead of recreating the wheel, it would be great to work on some common themes like tattoos and smoking and all those types of things that adolescents might want to do in terms of their own lifestyle choices.
Yeah, and especially when we're doing the research on this population too, it gives us more numbers, right? And so I think yeah, there's lots of good opportunities to be collaborative, I think, for sure.
And another resource I'll mention is that in the cardiology clinic, we have the good fortune of having a nurse whose job is transition, and so she really focuses on the education side of the transition preparation in terms of congenital heart disease. But she has lots of skills working with adolescents that can be, learned by nurses who work in different clinics, such as in the solid organ transplant clinics. So, if anyone is interested in setting up connections between a CHD nurse who's great at transition and other nurses, I'm sure I could help facilitate that. Simon, I see your hands up.
Oh yeah, thank you, and thank you for showing some of the previous work from Samantha and us around this topic. I actually had two quick comments. One, you mentioned 13. You think is a good age. In fact, we start at like age 10 to get our kids in charge of their own medication in the transplant group, because then when they become rebellious 12-year-olds and 13-year-olds, they don't think to use that as a blackmail against their parents. To not take their medication. So that's what we found quite useful. The other thing I just wanted to quickly mention, because I see there's quite a few adult representatives on this talk, is that we've just launched a task force at the ISHLT that's being currently kind of in preparation for transition in pediatric into adult, which includes both peds and adult to about equal numbers, because I think often once they transition, after all the work that we've put in, they are felt or perceived as normal adults. And as you said, with 18 or 20, you're pretty far away from being a mature adult most of the time. And so it's definitely looking forward to get more engagement there from the adult side as well.